Hello, my name is Frank Enseleit. I'm working in the University Hospital in Zurich in the Department of Cardiology. And my task today is to explain you how heart transplantation and assist device therapy work. First of all, let's have a look at the clinical course of heart failure. Usually heart failure starts with an event, myocardial infarction for example. And then usually we are able to establish a disease-modifying therapy to stabilize the course of the disease. If the patient does not die due to a sudden cardiac death, then at one point in time there will come cardiac decompensations. If cardiac decompensations are coming more often and often, then that's the point what we consider this is the transition to advanced heart failure. It's characterized by failing oral therapies. It's a time for major decisions. We should consider mechanical circulatory support or heart transplantation if the patient is eligible, or we should think about palliative care. If the patient has end-stage heart failure and he is on optical medical therapy including ICD and CRT, if the patient has a poor prognosis, and of course if he is motivated and well-informed and emotionally stable, he will undergo a heart transplantation evaluation. During this evaluation process, we look at the patient very closely. He has to be really in refractory heart failure. He has to have acceptable comorbidities. He has to have adequate psychosocial support and compliance to medical therapy, and the prognosis should be really poor. If the patient is eligible for heart transplantation, then he is put on the waiting list for heart transplantation. If he is not eligible, then we will evaluate him for destination therapy. To do a heart transplantation, there were many steps necessary. Many of them were developed during the first half of the past century. First of all, it was development of the right surgical technique, including the heart-lung machine. Then mankind had to gain insights into the immune system. Till on December 3rd, 1967, the first heart transplantation could be performed in South Africa. Another milestone in the heart transplantation was the development of cyclosporin A, an immunosuppressive drug which was developed in Switzerland. Because these immunosuppressive drugs have short and long-term side effects, and there's a shortage of donor organs, only younger patients with a longer life expectancy, especially patients with grown-up congenital heart disease, were considered for transplantation. Which are the factors for success in heart transplantation? We have many patients transplanted longer than 20 years in Zurich which are alive. But patients may die due to rejection. They may die of malignant disease, about 20% each. They may die due to graft atherosclerosis, around 15% of these patients have it, or they can die due to infection. What else can we do? Of course, we have ventricular assist devices. These devices will replace one or both ventricles of the heart. We have the left ventricular assist device, which replaces the left ventricle of the heart. We have biventricular assist devices, which were able to support both ventricles of the heart. And we have right ventricular assist devices, which replace the right ventricle of the heart. When it comes to different durations, we have bridge to decision therapy or bridge to bridge therapy. This is usually short-term therapy on the ICU. Then we have bridge to candidacy therapy, which means that the patient will be prepared to be able to get on a heart transplantation list. And then, of course, we have bridge to recovery, which means that the patient is bridged with a mechanical circulatory support system with a VAD till the heart is able to work on its own again. The next two possibilities are bridge to transplantation, which means that we support the heart with a ventricular assist device till the patient can be transplanted, or destination therapy, which means that the patient has a durable VAD as a lifelong therapy. How do we evaluate patients for destination therapy? Patients have to be really thick, and we measure this with certain tests, especially in the heart catheterization laboratory, as shown on the left side. Usually the patients have 3 or more heart failure hospitalizations within the last 12 months. They usually are failing to respond to optical medical therapy. The ejection fraction is usually quite low, below 25%, and many of them are IV inotropic dependent. And of course, when we put in a left ventricular assist device, the right heart should be working quite well. If these factors apply, then the patient is operated and the left ventricular assist device is implanted. If this is not possible, then the patient will go to palliative care. The outcome of destination therapy equals, after 2 years, that of heart transplantation. This is remarkable in nowadays. But there are problems as well. One is infection. The infection can develop at any point in time, as well as pump failure of the mechanical system. And the patient can have thrombi formation or bleeding complications. Thank you for your attention.